Hi, thank you everyone for joining us today. I'm Lisa Towers. I'm Director of Marketing for Lumina Health Partners. Appreciate you joining us for our webinar. Today we'll be talking about leadership in the law, driving quality and value in clinical integration. We are Lumina Health Partners. We're your partner on the journey to value. We are recognized industry leaders who assist healthcare providers in optimizing their strategic direction, financial outcomes, and operating performance. And these are some of our advisory services, so value-based strategy, digital innovation and analytics, clinical transformation, and leadership and governance. And today, our webinar content falls under value-based strategy. Our presenters today are Doug Ardoin, who is Managing Principal for Lumina Health Partners, and Tom Babbo, who is shareholder at Hogan Marin, Babbo and Rose. Welcome to both of you. Thank you so much for joining us, and I'll hand it off to Doug.
Thanks. Appreciate that, Lisa, and want to certainly welcome our good friend Tom Babbo to this to help us lead this webinar today. Today's agenda, so we're talking about leadership in the law for clinically integrated networks. And as you can see on the agenda, we're going to try to hit several topics. Certainly, Tom's going to lead us in the first two slides around Federal Trade Commission advisory opinions and statements of antitrust enforcement policy, which I think we will find very, very interesting. And then we'll talk a little bit about clinically integrated network business structure, different ways that organizations have structured either as a single health system or multi-health systems. Talk a little bit about chapter structure and physician leadership and roles, responsibilities in those programs, and then touch a little bit at the very end about the whole, so you have a CIN and you have an ACO, how can these potentially work together? So we'll talk a little bit about that, and then we'll take questions and have a little bit of Q&A also at the very end. So we will turn it over to Tom to get us started.
Hi, everyone. I'm Tom Babbo, shareholder at the firm of Hogan Marin, Babbo and Rose out of Chicago. Work with Doug and Lumina and lots of different implementations and development of clinically integrated organizations, accountable care networks, things of that nature. When we're talking about clinical integration, we probably always need to define our terms. So when we're talking about clinical integration, we're really talking about a network of doctors who come together around a common quality program, which gives them the ability to collectively negotiate for better reimbursement from commercial health plans. All things being equal, if without doing it the right way or just bringing competitors together as doctors are, that would otherwise be the most illegal thing you could ever do under antitrust law. Because the way that antitrust laws work is that physicians who are in independent practices or in different practice models, whether it's employed and independent physicians out in the community, they're seen the way that the antitrust enforcers would look at any competing sellers of a product or service, the same way that they would see a grocery store or a gas station or a hot dog stand. Physicians, when they come together, are competitors, and so you're automatically having to deal with U.S. antitrust laws. Luckily, we have a lot of really good, consistent guidance from the Federal Trade Commission and Department of Justice over, numerous years. They've come in the form of advisory opinions like the Norman PHO, Med-South, Suburban Health Organization, Tri-State, GRIPA. They come in the form of the 1996 and later FTC and Department of Justice policy statements. They come in the form of enforcement actions where the Federal Trade Commission has prosecuted and investigated organizations for potential violations of antitrust laws. And the result of all of that is that we get a great idea of what the enforcement agencies, and it says FTC here, and that's because the Federal Trade Commission is really tasked with enforcing U.S. antitrust laws with respect to healthcare. Insurance companies are enforced by the Department of Justice, and that's the way they sort of divide their labors at the federal level. But what we luckily have is a really consistent set of legal guidance and an analytics framework that should give everyone a lot of comfort in that we know what the enforcement agencies will consider clinically integrated, and we also have a good idea of what they'll consider to be not clinically integrated, what would get you in trouble. So, and we have also, from myself and my partner John Marin have developed more than 200 of these organizations around the country. So we have a really good sense of sort of how these also work, and Doug has worked with hands-on both at clinically integrated organizations and advising them. So we have a really good sense of sort of how they also look in operation.
While we're pulling up the next slide, I'd just like to say that I've never worked for any of those organizations that had an enforcement action.
Although I have, and Advocate Healthcare is probably one of the most renowned clinically integrated networks in the country, and they were in the midst of developing their clinical integration program while under investigation. So it's not necessary that people who have come under investigation are necessarily have done something wrong. It may be in some cases that they've just actually had to develop these principles, and the FTC had to figure out what was real and what wasn't real. So when it boils down to it, everything that we know legally about clinical integration can be boiled down to this definition that was given back in 1996. Back in 1996, after the last attempt at healthcare reform under the Clinton administration, really the only lasting vestige of the Clinton healthcare reform attempt were these Department of Justice and Federal Trade Commission policies that they set out about antitrust enforcement. And this really goes to what I was saying earlier, which is if it's true that you need provider collaboration in order to solve a lot of our problems in terms of the lack of quality and value in healthcare, that something had to give in the antitrust laws. Something had to, physicians and hospitals had to be comfortable that if they were going to do these collaborations, that they wouldn't be violating the law. And so what the antitrust enforcers did is they looked back at throughout, sort of the 150 years of antitrust case law, and they had to apply that to sort of the foundational document, which would be the Sherman Antitrust Act. And Section 1 of the Sherman Act says all contracts, combinations, or conspiracies in restraint of trade are illegal. If you took that on its face, it would invalidate pretty much every business transaction. So the way the courts have looked at it over the years is that there are some situations where behavior among competitors will be what they say per se illegal. If you're just getting together as a group of competitors to fix prices, you are a cartel. That's naked price fixing and will always be in and of itself illegal. That's what per se illegal means. There's also another, if you're not that type of an organization, if you're a joint venture under antitrust law, meaning you're coming together for some business purpose and you're creating what they call efficiencies. If you then might fall into what they call the rule of reason. The rule of reason is basically a scale, a balance. On the one end, you have this sort of automatic restraint on trade that always takes place if you have competitors working together. But if you can outweigh that weight of the restraint on trade with what would otherwise sort of these efficiencies that are created, improvements in quality, in cost, in the patient experience, then you're starting to, that rule of reason says that balance is tipped and you could be okay. And so they defined clinical integration. Back in 1996, they were wondering how doctors could get together and deal with managed care. One way was what they called financial integration, which was the sharing of substantial financial risk. That was really easy for the antitrust enforcers to understand in terms of how that would drive efficiencies, that if you're all at financial risk with each other, that creates a strong incentive to try to reduce cost. At the same time, there were doctors who were saying, well, this is healthcare, so shouldn't there be a way of collaborating clinically that creates an efficiency? And so then the antitrust enforcers said, okay, we're willing to grant that there could be certain ways that you could collaborate clinically, and that would be called clinical integration. And they defined it back in 1996 as a physician joint venture that creates an active and ongoing program among the physician participants to create a high degree of interdependence and cooperation among those doctors to control costs and ensure quality. Looking at that definition and trying to unpack that definition, we then can start to find out what clinical integration looks like in real life. So second down would be, what are the conditions then that are necessary? So you take that definition and you start to unpack it. What do you need? Well, you need a network of doctors who are willing to demonstrate that high degree of interdependence and cooperation through a program of initiatives that are designed to control costs and ensure quality, that's supported by an infrastructure, the technology, the staff, the leadership that allows those physicians to evaluate and modify practice patterns such that and very, very importantly, because you can do all of those things all the time. But number 4, if you're doing it in such a way to engage in joint contracting with commercial payers for arrangements that do not involve the sharing of substantial financial risk. A little sidebar on financial risk. There is no such thing as upside risk. When the Federal Trade Commission is talking about financial integration, they're talking about sharing actual financial risk. So a lot of times you hear in healthcare that this is an upside risk deal. There's no such thing. Unless you actually have downside risk, that does not qualify as financial integration. So your shared savings models, for the most part, on the commercial level, unless you're actually sharing substantial financial risk to the extent, say, of capitation or of substantial withholds, all of those arrangements require clinical integration in order to be legal. So we get to the legal test then. What is sort of the boiling down that 150 years of antitrust case law, all of these advisory opinions that I showed earlier, all of the enforcement guidance, all of the various consent decrees that have come down? What is the 3-part test for clinical integration? Well, first of all, you have to have a program, a clinical quality and efficiency program that's real, meaning that it's actually undertaken by the doctors, that it applies to each and every specialty on whose behalf you would negotiate. Because remember, we're trying to show that we're taking what would otherwise be competitors and creating efficiencies. So every type of physician that you intend to negotiate on behalf of, you have to be able to show 5 to 10 clinical measures per specialty that actually has an impact on the populations that you're contracting for. 2, you have to be able to show that those initiatives that you've put in place are designed to achieve likely improvements. Now, I phrase that very carefully. It's likely improvements. It's not that you have to show that it's absolutely certain. You just have to be very conscientious and responsible in developing these. And how do you do that? You look to the evidence, you look to the literature, you look to see what other organizations are doing, you look to see what payers are interested in. 3, and probably the most important part of this antitrust legal test, is whether joint contracting with the organizations that you're contracting with is reasonably necessary to achieve the efficiencies of the program. Okay, that's also another very weird and deliberate term, reasonably necessary. So first of all, it shows that the enforcement agencies don't expect it to be absolutely necessary to achieve the efficiencies of the program. In other words, it's not that if there is another way that you could achieve the efficiencies of the program in terms of quality, cost, patient experience, that you have to pursue it that way. It's that there has to be a really tight connection between the incentives that are created by joint contracting on the one hand and the achievement of those efficiencies. So really what we're trying to show, and it's a very true story because it's been happening all over the country, is that up to now, fee-for-service healthcare has basically been incentivizing the wrong things. That when you pay fee-for-service, but then you ratchet down on reimbursement per unit, what you're actually encouraging, if that reimbursement system is a language, is the creation of more units. And that's what you're telling, that's what the payment system is telling doctors what they need to do in order to be successful. So that there had to be we have to do something to change that reimbursement system to drive quality and value back into the equation. And what we're saying there is, in order to achieve those efficiencies of the program, that we really need to create economic incentives for physicians to improve quality and reduce cost. Because apart from that, today, doctors on their own in independent practices or in employment models have done about what they can do in order to drive quality and reduce cost. Hospitals by themselves, even though they've invested lots and lots in quality programs in the hospital, in order to get to that next step, you need to have financial incentives that just aren't present absent working with the payer system in order to achieve those efficiencies.
And Tom, at the end, I know you and I we're gonna talk a little bit more too about that. I think I agree with you. I think that's an area where a lot of clinically integrated networks struggle. And we talked a little bit about beforehand about, well, how clinically integrated do you need to be in order to joint contract? And I know we're going to talk a little bit about that at the end.
Why don't we deal with that right now?
Sure,
I mean,
sure.
So a lot of organizations, as we've worked around the country, a lot of organizations sort of feel like, okay, well, do I have to upset the apple cart? Why can't we just sort of do this by ourselves, start showing some efficiencies and then show it to the market, or not even get there. We don't want to offend our payers. The reality is, if you decided as a community of physicians or a hospital and physicians to sort of voluntarily drive quality and reduce cost, you come together sort of voluntarily outside of joint contracting, you're basically proving that you don't need joint contracting to achieve those efficiencies. And so the antitrust analysis would say you must not. So if you demonstrate that you don't need joint contracting, so if you're doing these things by yourself, you've shown that you don't need the incentive of joint contracting to do it. And so then the antitrust law would say, then you must not. Now, I think that's probably not true. I think you do need those economic incentives. But if you don't think about joint contracting from the very beginning, and it's not the wrong thing to think about, it's okay to think that this is about joint contracting or getting better reimbursement. Because if you can do it outside of joint contracting and better reimbursement, then you must not, according to antitrust law, according to what we call the ancillarity doctrine.
Yeah, and I just think, and I would agree with you, Tom, because I think without that, I think the risk to sustainability is too high of your program, and just the ability to say, okay, where do we go next? Because there's
right.
certain investments that we need to make as a network, maybe technology, maybe other things, and this is going to help us get to the next step and the next step and to continue to get better. Otherwise, we're only going to get so far, and then it's likely not to be sustainable. So.
Right, and that's really how a free market system works. A free market system works because the market creates conditions that create incentives to be more innovative. But in order to sustain that the ability to be innovative, there needs to be on some level, even though doctors are practicing medicine because of a sense of mission, but also there has to be that sort of market incentive of the economics of healthcare to incentivize people to continue to sustain these improvements.
But Tom, so this slide, that talks kind of like a single health system. This was very similar to the first time I had a leadership role in a clinically integrated network. It was a single health system. As the parent, the subsidiary was the clinically integrated network and had the system hospitals, and then a pretty healthy mixture. I'd say about 80 to 90% independent private practice doctors, about 10% were employed in academic. But yeah, this is kind of what it looked like. What are your thoughts on this model?
I mean, this model is basically sort of again, as I talked about earlier, about sort of unpacking that definition about how it becomes real. So this is how you develop the clinical integration in real life. It also shows how a hospital system, I think, and actually this looks like a lot of the organizations that we've developed around the country, hospital systems, because they tend to be the coalescing force. Now you could, I suppose, most of the organizations that we've worked with around the country have been sponsored by health systems. We've also worked with some organizations that are just independent physicians who come together to do that. That means that the physicians themselves have to finance it. But I think what's important about this slide is that if you're a health system that's interested in aligning with physicians in trying to drive quality and reduce costs, and you want to work with your doctors, that you can create a wholly owned subsidiary where you're providing a lot of the infrastructure that supports this. And this infrastructure can be provided entirely by the health system. Now, this organization itself, if you look to that sort of that dotted circle below, it has a board, and that leadership. Now, we tend to set up these as wholly owned subsidiaries with substantial reserve powers remaining in the health system, which allows the health system to provide the physicians with a predominance in governance. So the governance of the organization can be predominated by doctors. In some states, it actually has to be. So in places like Texas, you would want to set up this company as what they call a 501A, and that would be an organization that must be governed 100% by physicians. But even if you're not in a state where there's restrictions on that, just to make this work, you want an organization that's governed predominantly by physicians. Now, the reason that we think it's a great idea to set it up as a wholly owned subsidiary, if it's a hospital sponsoring it, not as, say, like an old-fashioned PHO, that's sort of 50-50 owned by the doctors and the health system, is that if you do that, then you're in a situation where under prevailing tax law and other anti-kickback law, that you would have to make sure that the physicians were putting in as much of an investment as the health system, and you would have to do that forever, which could be, in most cases, unsustainable for it's just not affordable for physicians in practice to fund an organization with the kind of infrastructure that you need in place in order to accomplish clinical integration. So what you're able to do with a health system is to create a wholly owned subsidiary that actually is able to finance the operations of this for a long time without asking for reinvestment from them. Now, and we'll probably get into this later on, or we can certainly do this in terms of Q&A, but obviously over time, this organization should then demonstrate that it's self-sustainable in terms of its contracts and incentives that it's able to negotiate with health plans. But setting it up as a wholly owned sub allows you to set this up in a way where the health system can provide a lot of the financing and the operations for the organization.
This is another model that I've been involved with where you try to do kind of a super CIN where maybe you get regional health systems across the state or across a large geography who want to come together. They may already have their own existing clinically integrated networks, or they may not, but they want to come together and form something across a larger geography. In the instance where I was, these organizations were not competitive. They just had a bit of a vision that they wanted to improve quality and outcomes across the state that they were in, because they weren't ranked as high as they'd like to be, and they thought through a clinically integrated network approach, they could organize their physicians and bring them together across markets, across geographies, developing quality and efficiency programs, and then also as a larger statewide network, be able to jointly contract. And so I think this is probably a little bit more new over the last few years than what we've seen traditionally.
Yeah, this is really emerging. When we were doing this back in the early 2000s, we were really seeing it with single hospitals or hospital systems doing this. Now we're seeing these conglomerations of numerous CINs, as you said, Doug, across a state or a region. We're seeing it across numbers of states. So where they sort of have in states that sort of border each other. It's sort of the real innovative and emerging model. And it could also even be health systems that you mentioned, Doug, that that don't really compete with each other, even though they're in the same sort of geography. You can actually do this with competing health systems in the same market.
Yeah, I know we were going to address that a little bit too at the end, and I think you have to be kind of careful there. If correct me if I'm wrong, Tom, but
absolutely.
But I mean, you really do have to be careful if you're going to be in the same kind of marketplace and you want to clinically integrate, say, across hospitals. There needs to be a lot of consideration to service line coordination, a shared quality program, a shared efficiency program, and it's got to meet all the other criteria that you so nicely put up at the beginning of this presentation around this. It's got to be real. The programs have to be real and have to be aimed at truly improving the quality if you want to be able to jointly contract even as competitor hospitals in the same market.
Yeah, and you really want to do it with guidance. So you want to do it with the guidance of people who understand how to do this, both from an operations and clinical standpoint, as well as, you need to consult. Obviously, if you're ever considering, if you're considering clinical integration in general, you always want to engage your whether it's your in-house counsel or your local counsel, but also you want to make sure that you want to engage people that really have expertise in this area, because it's even though we've been talking about this as something that's very positive and innovative and good, it's also something that's complicated enough that you need help.
I'd just like to hit a little bit on this. I'm not obviously there's a lot of information packed on this slide, but the biggest take-home message here is all about physician leadership.
Absolutely.
If whether you have a clinically integrated network today or you're thinking about putting one together, the physicians have to be in leadership positions as you can see, from the governance perspective on your board, managing committees, and really driving the strategic direction of your clinically integrated network. Your physicians have to predominate, and they have to be in leadership roles. When it comes to developing the performance measures, and not just the measures, but then your performance management program, your performance improvement program, remediation policies, and things like that. Your physicians need to be in the lead, and they need to be the ones who are executing on this and putting these aspects of your program forward. Developing and putting in clinical management, like clinical guidelines or what have you, this is the domain of your physicians. Education is very important, and I think that your physicians should lead, and I think it should be a requirement for all clinically integrated networks, and this is just me talking, but I think it's a nice requirement to have education as a citizenship measure within your clinically integrated network, that all of the physician participants are required to do a certain level of and mandatory education throughout the year, so that it's clear that everybody understands and clearly gets the point about what clinical integration is about. And then physician engagement, physician recruitment, physician ambassadors, things of that nature, and even to how you develop your performance-based incentives and distribution methodology. The take-home message here is that if you're going to be clinically integrated, your doctors have to be in the lead, they have to be involved, and they have to be kind of driving the program. Tom, do you have any thoughts?
No, absolutely. I mean, and not only is it what I've always thought is that in order for clinical integration to actually work, it needs to be physician-driven, physician-led. But it actually also supports, this is one of the rare circumstances where the law behind this actually supports the business and clinical strategy, and you don't have to find a way around it. This actually, if your doctors, whether it's from governance or your rank and file doctors, aren't actively involved, then from an antitrust standpoint, from a FTC, Department of Justice standpoint, you're not, if it's the hospital that's doing all of the quality efforts, the physicians really aren't engaged, you're actually not demonstrating that the physicians are integrated, which means, again, that instead of creating a clinical integration model, you've created a cartel. So you really must have physician engagement, physician education, and throughout every every level of your organization.
It goes back to the original definition: active and ongoing participation, right?
Exactly.
And we just want to throw this slide in real quick. I know a lot of organizations, say, well, we have a clinically integrated network and we also have an ACO. Can those be the same, or do they have to be separate? But can they share resources, maybe share committees and what have you? And I think the answer to that is you can certainly share resources. You can certainly share technology committees and what have you. But I'm going to let Tom speak a little bit more expertly about, though, there needs to be a division or a firewall between your CIN and ACO. And so, Tom, I'll let you comment on that.
Yeah, it makes a lot of sense we think it makes a lot of sense to operate your CIN and your ACO as a common enterprise. We think there's also really good reasons why you would want to have them be separate organizations from a business entity standpoint, and in terms of the governance and in terms of the reserve powers that you cannot have in an ACO that you can have at a CIN, in terms of some of the waivers that you can have as an ACO that you don't necessarily get as a CIN, although I don't think that should be an obstacle because there's other ways of operating without a waiver completely legally. But it makes a lot of sense to, especially because of the regulations around governance and around the operations of a Medicare Shared Savings Program ACO or a next-gen ACO, that you would want to set them up as different companies. At the same time, you really want to operate them, if you're going to do this in a smart way, you want to run them as a common enterprise with very overlapping governance, and potentially even making sure that you're even aligning your quality metrics, your quality program, your infrastructure in a common way around everyone.
Well, I know that was a lot of information in just a few slides, but I think that was the last slide. I think we're open for Q&A at this time.
Our first question: if a hospital or health system is the parent company of the CIN, for how long can the parent financially support operational costs?
Antitrust is not the only issue that we're dealing with when we're developing a CIN. We're also having to deal with Stark. We're having to deal with, if it's a tax exempt, that's the parent, we have to deal with tax exempt law. So there has to be, as I mentioned earlier, there has to be at some point that the entity starts to create a return. But, in general, again, I'm going to shortcut the legal analysis here. But in general, what we see is you can find justification for a health system to fund an organization for a good 3 to 5 years. Now, obviously, it has to drive value back to the health system. So a health system, if you're creating a wholly owned subsidiary, as we've suggested earlier, a health system can fund a company that it owns. So there's that. It also needs to be able to show, and something that you need to show a good narrative around, is what is the value back to the health system, so that this is not simply a giveaway to physicians. So how does the quality programs support the hospital's mission, both in the community and in remaining competitive? How does it drive quality and efficiency in ways that the hospital is unable to do, as I mentioned earlier? So hospital can fund these organizations very heavily in the startup phase and even beyond the startup phase, as long as there's value being generated back to the health system.
And our next question is, what is the rationale to charge an annual membership fee to providers to participate in the CIN?
This is a good question. Tom, I'd like to hear your thoughts because I've seen it go both ways where the CIN you'll charge a modest fee annually and then sometimes they don't. And that does come up quite a bit. So what do you think of that?
As I said earlier, if it's a wholly owned subsidiary of the health system, really what you're looking at is not a physician investment, but you're looking at it as physician dues. Then what you're trying to do is to make sure the doctors are serious, and a lot of times charging a fee creates a sense that this is something of value. And so it sort of separates physicians that might not be as serious in taking on the hard work of clinical integration as otherwise. That doesn't mean that you must charge a fee. And a lot of times if you have organizations where there's other competing CINs in the market, it might make some competitive sense to not charge a fee. At the same time, it might just show that this is something that you're showing. If you're charging dues or charging a fee to join, it sort of sorts out the serious physicians from the unserious ones.
And our next question, if the CIN wishes to purchase analytic software to measure and monitor performance, does the CIN need to charge participants for access to the system?
Yeah, that's another good question. I've seen that a couple of times too, and maybe we can also. The other thing that also comes up is, after we talk a little bit about analytic software access, EHR, and the stark exception for EHR, and if CINs can use that. So, Tom, what do you think on? Do you have to charge physicians to have access to the quality and cost analytics software?
Well, in terms of the cost, the analytics software, having access to that, I think that the question would hinge on whether that is a benefit to the physicians or if access to that software is actually something that creates an obligation and extra work on the part of the physician. So I think in a lot of cases, if this is software that the entity needs in order to demonstrate its performance on its contracts with payers, I don't think that that's something that you would necessarily show is a benefit that you're giving to the physicians necessarily. Obviously, the contracting is, but also the physicians are working with respect to those contracts.
I think that's a great point. I hadn't really ever thought of it that way, but you're right. I mean, it is the whole intent of that is we're going to put this in, we're going to generate, it's going to collect data, we're going to generate reports. And hey, physician, we expect you to look at this. Matter of fact, it's going to be an obligation of being a part of the clinically integrated network. And this is one of the ways that this is active, this is ongoing, and this is about changing practice patterns. And this is how we're going to inform you. So that's a good way to think of it.
Now, if you want to be super, 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 super careful, I suppose you could try to find, you would maybe want to create a good narrative around, again, what is the value that the physician has to invest in making that system work? There are, we've seen even when people have, even this is very, very lately, we've seen valuation, fair market valuations being done when an organization is being sold or to a health system, or a health system is trying to justify its investment. They'll go out and get a fair market valuation. We've seen valuations today, as opposed to say in the past where we didn't have a lot of background on this, but valuations coming in very high based on sort of that sweat equity almost concept. The physicians of the time and effort the physicians are putting in to making these systems and these organizations work can really show that this is a very significant investment of human capital on the part of the doctors.
And the EHR, the EMR question, what do you think of that?
Well, I mean, we have existing statutory exceptions and safe harbors under Stark and any kickback. You'd want to follow those. If it's the health system that is financing the EHR, at the same time, for a more mature organization that has bonus funds, so say if you have shared savings coming in that maybe the physicians haven't earned because of the bonus criteria that you put in place, maybe try to use that residual funds to reinvest in something that's going to help them to comply and do better on their program on EHR. So a mature organization can use funds that it gets from payers to, that maybe haven't been earned by the doctors, to invest in buying an EHR for those physician practices.
And our last question, is it necessary to do an FMV analysis of program reward distributions to participants?
And there I would say no. When we're talking about incentives that are coming from the payer, so under your health plan contract, that's money that is part of the value that is part of the value of the negotiation between not the health system and the doctors, but between the doctors and the health insurer or health plan. So there you wouldn't really need a fair market value calculation. It's basically the reimbursement, whether that's in enhanced fee schedules or in bonus payments, whether that's shared savings or otherwise. That doesn't require a fair market value. What would require fair market valuation is if the health system wants to use this network now of committed doctors around quality to drive specific efficiencies in the hospital by creating a hospital quality efficiency program where the hospital contracts with the CIN or ACO to really start driving efficiencies and cost reductions in the hospital. There, if you come up with that type of a deal between the health system and the physician network, there you would want to follow, good practices. You'd want to get a fair market valuation on that. And and that's also something that there's lots of experience out there now around the country where a valuation consultant can do that fair market valuation, looking at comparables from around the country.
I think that's great guidance. Yeah, and I think the differentiation there between what you've earned from the payer versus what you're going to do internally with the hospital efficiency program, I think that's great guidance.
Great. Well, thank you so much for that great information, and that concludes our Q&A section of the webinar. We thank you again for joining us today. If you'd like to get in touch with Dr. Ardoin or Mr. Babo, you can email them directly at the addresses listed on your screen there. And we'd also invite you to check out our website at luminahp.com. You can follow us on Twitter at LuminaHP, follow our LinkedIn company page at Lumina Health Partners, and also check out our Lumina YouTube channel where this webinar and our previous webinars are also posted, but this one will be posted within the next week. So we invite you to check out those resources. And again, we thank you for joining us today. We hope to see you on a future webinar, and we hope you have a great afternoon.